Hello, everyone. My name is Rowan Ferran, and I'm a research assistant here at Health Evidence. We are very pleased that you are able to join us today to talk about the effect of weight loss interventions on mortality and morbidity for adults who are obese. I will be introducing in a few moments Dr. Alison Avenell and Sam Ma, who we are thrilled to have joining us today to present their work in this area. We would like to take this time to wish a warm welcome to our presenters today and also to welcome all of our Health Evidence users that have joined us for this webinar. Throughout the session today, we'll be posting polling questions through the WebEx platform. Your participation in polling questions is voluntary and anonymous. I'll just leave the consent slide up for a moment for everyone to read through and then move on shortly. Just to let everyone know that after today, the PowerPoint presentation and the audio recording will be made available on Health Evidence's YouTube and SlideShare accounts, usually within the next week or so. The links to both of those resources will be posted in the chat section, which is being monitored by our research assistant, Grace Thomas. So please feel free to connect with her there if you are having any technical issues, have any questions, or need assistance. Today, we are very excited to be talking about the review, Effects of Weight Loss Interventions for Adults who are Obese on Mortality, Cardiovascular Disease, and Cancer, Systematic Review and Meta-Analysis. The link to the Health Evidence Review page for this systematic review will be posted in the chat section. You can click on the link and follow along in the review using the article, full text, or PubMed link out. Today, I'd just like to mention a few housekeeping items before we begin. Please use the chat section in WebEx to post your questions and comments. We ask that you send your questions or comments to all participants and not just to the host so everyone can see them. Also, please feel free to post your questions and comments throughout the session. Towards the end of the session, we will save some time for the presenter to respond to any questions or comments you might have. Also, for the best connection, we recommend that you use a wired internet connection versus wireless. And should you have any connection issues, we have posted the 24/7 WebEx helpline on the slide as well as in the chat section. For your audio today, please listen through the speakers. If you are having any trouble hearing, you can go to Communicate at the top bar in WebEx and then click Audio Broadcast. So we have our first polling question of the day right now, which can be found on the right-hand side of the WebEx platform. And what we are wondering today is just how many people are watching today's session with you. Is it just you, 2 to 3, 4 to 5, 6 to 10, or more than 10? And please make sure to press the Submit button at the bottom after you have selected your response. So thank you so much for taking the time to answer. I can see here that a lot of people are watching on their own, but we do have a couple of groups of 2 to 3, which is great to see. Okay, so moving on to our next slide. We would like to give a special thanks to our Health Evidence team who have worked to bring this session to you today. There is a large team of us who work to keep Health Evidence current and maintained, as well as coordinate this webinar series. Okay, so for those of you who may not be familiar, the Health Evidence is a service and research organization involved in knowledge translation for public health professionals that was launched in 2005. Our main product is a comprehensive registry of reviews where we provide over 5,000 quality-rated systematic reviews evaluating the effectiveness of public health and health promotion interventions. The main goals of Health Evidence are to make evidence relevant to public health more accessible and make it easier for professionals to use evidence in decision-making. The value add for using Health Evidence is that we save you time. We have done the work to screen and appraise each review within our registry. We screen all reviews for relevance to public health and keep our repository up to date by constantly screening relevant databases. At any given time, we are no more than 1 to 2 months behind the publication date. We have done the work for you by critically appraising all reviews through a transparent process, whereby you can actually click on the full quality assessment of each review and see our rating for each of our 10 assessment criteria. The Health Evidence website also has various tools and supports for evidence-informed decision-making, or EIDM, available online, and many users have informed us that our tools and repository are both easy and simple to use. So now I'm just going to quickly touch on the model for evidence-informed decision-making, which we can keep in mind as the presenters go through the systematic review today. This model consists of 5 components that you can see in the diagram on the slide. Public health practitioners and decision makers need to consider evidence from a variety of sources, including community health issues and local context, existing resources, community and political climate in making decisions about programs and policies, and research evidence. The Health Evidence webinar series is designed to highlight findings from research evidence relevant to public health decisions. So on the next slide, we can see the stages of the evidence-informed public health that illustrates the steps involved in evidence-informed practice. So the wheel is a guide for practitioners and decision makers to determine how to address a particular issue by systematically incorporating research evidence into the decision-making process. There are 7 steps outlined here, and today we will focus on how the presenters have worked through the first 4 steps of this process in order to help support public health decision makers and practitioners with the remaining steps in this process. So now we have our second polling question here, and we were really wondering how many participants today have heard or are familiar with the PICO-S format or process. And again, please don't forget to press submit as you answer these questions. So from what I can see here today is that there are quite a few people that are familiar with PICO-S and a couple that are not. So what we're going to do is kind of discuss, for those of you that are not familiar with PICO-S, we're just going to discuss that a little bit and how you can use that as a way for you to structure your research questions. So PICO-S involves defining the population that you are interested in, what the intervention program or service is that you want to know about, the comparison group, if any, and outlining the specific outcomes you are looking for. Sometimes we also have a particular setting in mind, which we can also state here, for example, school or community setting. The value of a PICO question is that when you have an issue that arises, you can use PICO to turn this into a searchable question, which allows you to further articulate specific components of the question and can then help you to search for relevant information related to your PICO more easily and efficiently. Okay, so moving on to our third polling question for today. We want to see how often you use systematic reviews to inform programs or services. So is that always, often, sometimes, never, or I don't know what a systematic review is? Okay. So we have a couple of people that always use it. We also have, I see the majority of people often use systematic reviews. So thank you so much for your answers. And we will move on. So I will move on now to introducing our presenters. We are really excited to have Dr. Alison Avenell and Sam Ma today to present the findings from their recent review. Dr. Alison Avenell is the Clinical Chair in Health Services Research at the University of Aberdeen, and Sam Ma is the Foundation Year 2 Doctor, also at the University of Aberdeen. Thank you both very much for joining us today, and I will pass along the presentation to you.
Right. Very much for inviting us to present the results of our systematic review today. I should just say to everybody that Aberdeen, in case you don't know, is in Scotland, so that's where we're giving our talk today. So our systematic review was published in the BMJ and it is open access, so if you want to read the full text of it, it is readily available for everybody. And we mainly conducted this with people working at the University of Aberdeen, but we also had one of the team based at the University of Auckland in New Zealand. We go to the next slide. We have no disclosures at all to tell you about. This work was undertaken by Sam as a medical student. He's now just qualified as a doctor, and we had no funding. It was done as his project for his bachelor's degree. So Sam's going to take you through the introduction and the methods, and I am going to talk about the results. Just a little bit to inform you about why we did this project in the first place. There's been huge debate about whether, in fact, people with lower levels of obesity are at increased risk of disease. Some evidence has suggested that people perhaps with BMI 30 to 35 have reduced mortality in later life, early later life, and particularly for people with cardiovascular disease, the epidemiology has suggested that after a heart attack or cardiac failure, you might actually have a lower risk of dying if you were obese. Also, there's been criticism of dietary guidelines for lack of evidence base, so we thought it was really important to look critically at the evidence for weight loss, and Sam's going to take you through this in more detail.
Great. Hi, everyone. So just going to talk a little bit about the background of obesity. So most people, I think, know what obesity is defined as, and it's the WHO definition as a body mass index, which is given by the weight in kilograms divided by the person's height in meters squared, and that's more than 30. Obviously, in the world, there has been an increased prevalence of obesity, and that's not only in Canada and America, but it's also in most parts of the developed and also the developing world as well. At the moment, there's about 650 million adults worldwide who are obese by the most recent WHO surveillance data, and also there's been an increase in childhood obesity as well. And you can see about a quarter of the population, both Canada and the UK, are in fact obese. And also the levels of obesity are predicted to increase with time. This data was taken in 2011, which suggested that Canada only had obesity in terms of about 19%. However, we know that in 2018, the predicted levels have fallen short of what the actual levels of obesity are based on this graph. And with obesity, there is predicted to be increase in diseases in association with obesity, and that includes type 2 diabetes, high blood pressure, and also cardiovascular diseases as well. And that has associated costs in terms of both health and social care costs as well. And we know that obesity is not only related to heart disease, it's also related to certain cancers such as endometrial cancers, esophageal adenocarcinoma, liver cancer, and kidney cancers, as well as others. And that can be due to a variety of different reasons, either due to hormonal changes or due to long-term reflux causing increased risk of Barrett's esophagus and therefore adenocarcinoma of the esophagus, as well as changes in adipokines and factors such as insulin-like growth factor. So whether deliberate weight loss can be beneficial for patients in terms of reducing the risks of these diseases and cancers, as well as mortality, is not fully known. In fact, a study published in 2013 in JAMA suggested that patients with higher BMIs above the normal range of 25 to 30 may in fact have a lower risk of mortality than those with normal or lower BMIs. This is what is known as the obesity paradox, which has been heavily debated by different epidemiologists and researchers as to what's the exact cause, and also whether this is true when it comes to real-life practice in terms of data through randomized controlled trials. There has not been any study which suggests or gives a clear evidence from a single trial as to what whether losing weight or having a lower BMI or normal BMI may in fact be harmful or in fact be beneficial. However, there has been a data which was published in 2016 in the Lancet, which suggests, based on data from 1.8 million participants in 239 epidemiological studies, that in fact the safest BMI to have with lower risk of mortality is in fact 22.5 to 25 kilograms per meter squared. And that is based on using patients who were non-smokers without pre-existing illnesses, and they avoided data within the first 5 years of follow-up, as well as the fact that the data collected was based on individual participants and not based on aggregates of data, as sometimes in epidemiological studies. You can see that the data was consistent by gender, so both male and females had the safest level of BMI as around 24.5, and similarly by the different causes of mortality, such as heart disease, respiratory diseases, and cancers, that the safest levels of BMIs to have were also around 24 as well. One systematic review has been performed before our systematic review, and this mainly looked at whether weight loss interventions had a beneficial effect in terms of reducing mortality for individuals who were overweight or obese. And this was published in 2015. They found a non-significant reduction in the risks of mortality, given by its confidence interval reaching 1, and also they did not look at cardiovascular disease and cancers, whether these were affected by weight loss interventions. So our question was really whether conservative dietary weight loss interventions, with or without an exercise component, for individuals who are obese with a BMI above or equal to 30, compared to a control intervention which did not facilitate these things, may in fact reduce the risks of mortality, cardiovascular diseases, cancers, as well as cardiovascular mortality and cancer mortality as well. We also had a weight change as one of our outcomes as well, to ensure that the actual interventions that we've utilized were effective in losing weight. Subgroup analyses were performed within the study itself, and that was looking at whether age and gender having different cutoffs for BMI, less than 35 or more than 35, whether the patients had type 2 diabetes or impaired glucose tolerance or impaired fasting glucose, or did not have diabetes, as well as the interventions, whether they were whether physical activities facility and advice was provided, or whether no physical activity advice was provided at all, as well as different ethnic groups to see whether they made an influence to the data in terms of the effects on both mortality and morbidity for obese participants following these weight loss interventions. We also did sensitivity analysis, which was looking at whether allocation concealment, so whether the patients knew which arm of the randomized trial they were on, and whether that would have made an influence to the actual desired outcome, as well as the participant follow-up rate at the end of the study. So, and we also included a sensitive analysis which was looking at cardiovascular outcome data as defined by the Journal of American College of Cardiology definitions. A flowchart of our review process, so our inclusion and exclusion criteria are provided there. And we have also had, so we have excluded participants who were pregnant or were in the early phases of lactation. In terms of what data we had, so we undergone a screening of abstracts from 2015 to 2016, as well as used our existing database of randomized controlled trials, including participants who were obese following dietary conservative weight loss interventions with or without exercise components, which has been collected since 1996 until this year. And this is being updated regularly by the HSRU, which is the Health Service Research Unit here in Aberdeen. So altogether, we screened 5,900 abstracts and over 1,100 full text reports looking for outcomes such as deaths, cardiovascular diseases, cancers, and as well as deaths caused by these two types of illnesses. And we found altogether 54 randomized controlled trials which fulfilled our inclusion and exclusion criteria.
So I'm going to talk you through the results. So altogether from the 54 randomized trials, these included over 30,000 participants in the trials, and in more than 3/4 of the trials, the participants had obesity-related comorbidities such as diabetes, hypertension, osteoarthritis, or cancers related to obesity. And the trials had to have a minimum follow-up of at least 1 year, but some of the trials followed people up for a great deal longer, and the longest time point for follow-up was over 12 years. Most of the trials were in the USA or Europe. There were a few in Australasia and a few in Asia. So first of all, the weight loss data and meta-analysis, and I apologize, we didn't realize until just before we were due to start the seminar that the webinar icons obscure the bottom part of the meta-analysis, but you can see we have an enlarged representation of the bottom line to the right of the slide. And what you see is that the risk ratio for premature mortality from 34 randomized trials presenting mortality data is significantly reduced at 0.82, with confidence intervals of 0.71 to 0.95. So from the 34 randomized trials that provided mortality data, there is an 18% relative risk reduction for premature mortality, and this equates to about 6 fewer deaths per 1,000 of the population undergoing these interventions. Then if we look at the effects on cardiovascular mortality, generally trials provided mortality data, but they didn't say what people had died from, so we only had 8 trials with cardiovascular mortality data, so the quality of the data is very poor, unlike the quality of the data for all-cause mortality, which was high-quality data. And you will see that the relative risk for cardiovascular mortality was 0.93, and there are very wide confidence intervals. So we couldn't conclude anything from the effects on cardiovascular mortality. Similarly, for cancer mortality, again, few trials were specific about the causes of death, and so again, we have a lower risk ratio, relative risk of 0.58, but again, with very wide confidence intervals. Now, if we move to participants who experienced a cardiovascular event after taking part in a weight loss intervention, we have data from 24 randomized trials. And what we see actually is that the relative risk is reduced at 0.93. The confidence intervals are tighter, but still do not encompass, they still encompass 1. So we can't be certain that there is truly an effect on cardiovascular events, but the evidence is fairly high quality based on our grading of these, this systematic review. We also looked at the data using a tighter definition of cardiovascular events, and so as opposed to 24 randomized trials, this narrows the events to data from 17 randomized trials, and the results are pretty similar. And then looking at cancer events, this was reported by 19 of the trials, and again the relative risk was lower at 0.92, again wide confidence intervals, and so we couldn't be sure about the effects on cancer events. Sometimes also it was rather difficult from the trials to be sure that they were talking about new cancers rather than people who may have had a pre-existing cancer and developed a recurrence. So looking at the effects of these interventions on weight loss, you will see first of all that at the end of 1 year we have a huge variation in the amount of weight loss from the various trials. The trials are very heterogeneous in terms of the weight loss that they produced in their participants, but the mean difference was around about 3.5 kilos at the end of 1 year. And then on the next slide, you will see that by the time we get to 2 years, the number of trials presenting data at 2 years was slightly less, but still very heterogeneous, and the average weight loss had fallen a little to around about 2.5 kilos. And then we also looked at the final weight loss in trials that followed up for longer, and this was still around 2.5 kilos. And the period of follow-up for these lasted for as long as 9 years. This is rather a complicated slide, but it shows the effects of our main outcomes from adding in the 4 studies which took place in Asian groups. For the Asian groups which we included in our post-hoc analysis, we allowed a lower BMI of 25 or over. There is debate about the BMI cutoff that should be used in Asian populations to indicate an increased risk of morbidity from obesity, and countries such as Japan and India have tended to suggest that BMI should be the cutoff. So we included 4 other trials which had provided some of the outcomes we wanted, and along the right-hand side in the final column you will see that essentially the outcomes were unchanged by including those 4 other trials. So what were the results of our subgroup intensity analysis? There was some suggestion, and we have to reiterate, we did many subgroup and sensitivity analyses, partly because we thought people would ask for them, but there was some suggestion that people without diabetes or without impaired glucose tolerance had a lower risk of cardiovascular events compared to people with diabetes undergoing weight loss interventions. And there was also some suggestion that people who were from Caucasian background were more likely to benefit from weight loss interventions than those from other population groups. As I emphasised, this is a subgroup analysis, and really we'd have to have an awful lot more trials and data, probably individual patient data, to confirm those findings. A lot of our trials had very few events, and so in order to check that we had interpreted the data, we also did a Bayesian analysis of our results, and this was consistent with our conventional meta-analyses. And our other subgroup analyses had shown really that the effects for mortality, cardiovascular mortality, cancer and cardiovascular events were pretty consistent, irrespective of age, whether the BMI was over or under 35, and whether interventions included physical activity advice or a program or didn't include those. So the bottom line really at the present state of play, because we would like to update this review in the future as more trials continue to publish our results, is that weight-reducing dietary interventions do reduce the risk of premature all-cause mortality by about 18%. The effect is small, but it does relate to 6 fewer deaths per 1,000 participants. It seems pretty consistent across the populations in these trials. And one thing that we found was that all but one of the trials included in our review evaluated low-fat, generally less than 30% energy as fat, low-fat reducing diets, low in saturated fat, high in complex carbohydrate. So they were not looking at Atkins-type low-carbohydrate diets. So we think this gives some added credence to conventional, if you like, dietary guidelines for low-fat reducing diets, low-fat diets in terms of public health benefits. As I reiterated, the subgroup analyses really may relate to the fact that we did lots of testing of different groups. So the limitations of our study, we did have few data for our other outcomes other than all-cause mortality, particularly the cancer outcomes, and a lot of times the data that we used were not data that the trialists had as a primary or secondary outcome. They were adverse event data, and therefore they may not have been collected so rigorously as if they had been primary or secondary outcomes. Nevertheless, we think it unlikely that trialists would neglect to present the numbers of participants who died when they were following them up. And we also had a lack of power for subgroup or sensitivity analyses, such that individual patient data analyses in trials would be good to undertake. So in our acknowledgements, we did collect an awful lot of data from the trialists by contacting them, asking if they had extra data that could contribute to the meta-analysis, and also asking them to clarify some of their numbers. And also there were many other staff in our department who helped us with their support and time. We registered our protocol ahead of time, and here is the link to our Prospero registration. And on our next slide, here are the references that we have given in our presentation today. I think that finishes our presentation. Yes.
All right, thank you very much for that lovely presentation. It was great, and it was very interesting to hear about the potential impact of weight loss interventions on morbidity and mortality. We really appreciate you sharing this walkthrough with us today. So we have a few questions already, and just a reminder to participants that you can start to add any questions or comments that you may have in the chat section of the platform. What we'll do is I will read those out to our presenters, and then they can answer them for you. So we will start with the first question today, and that is it fair to say that the number needed to treat is 166 in other words, 1,000 over 6. Again, in other words, that we would need to offer weight loss interventions to 166 obese patients to save one premature all-cause death.
Yeah, that's bottom line, yes.
Excellent. Another question is, what is the biggest takeaway you would want policymakers to get from this presentation?
Yes, I mean, it's an interesting question. One lives in hope that policymakers would take on board the fact that there is evidence that eating healthily, losing weight a little bit by eating a diet which is healthier, lower in fat, fewer calories, actually can be beneficial and reduce premature mortality, and that this has major implications, I would like to hope, for the way that governments deal with food industry in their regulation and the kinds of products that are available and promoted to the public. That's the bigger implication, I think. I'm not sure that policymakers would necessarily take that on board, but one lives on hope.
Excellent, thank you so much. Another question that we have here is, can you comment on the descriptives of some of the interventions included in the review? For instance, were they community-based, who ran them, the age range, things of that nature?
The trials that were excluded from the review?
No, the interventions that were included. So commenting on the descriptives of some of the interventions included in the review.
Hold on. I can give you a bit more information about the interventions. So basically, let's look at age. It has to be said that very few of the interventions were really in an older age group. We had about a quarter of the trials where the average age was over 60, but usually it was just in the low 60s. So it's difficult to translate this information to older people in their 70s and 80s, which I don't know about Canada, but certainly in the UK, obesity in older people in their 70s and 80s is becoming an increasing issue, and people are not sure what should be done. And BMI prevalence is almost as high as people in their 50s and 60s. The interventions were spread across all different settings. There were many studies that were in communities, hospitals, but generally they were interventions that were in volunteers, of people who had signed up for the interventions. So you're probably looking at a particularly motivated group of people rather than if you have people who turn up at their primary care physician who says, I think you need to lose some weight. That may not necessarily reflect the kinds of people in these studies. Anything else you would want to know?
I think you covered a lot of that. You covered age range, community-based, also who ran the interventions. Do you have some information around that as well?
Well, generally these were pretty intense interventions, so they usually did have input from dietitians or people with psychology expertise or exercise physiologists in addition. I mean, the trial that provided most of the cardiovascular event data is obviously Look Ahead. I don't know if your participants know about Look Ahead, but this was a trial in the US that was a very intensive intervention in people with type 2 diabetes that had considerable input from various personnel, dietitians, psychologists, exercise experts. So there are relatively few trials which are, for example, commercial weight loss interventions in this review, or ones where it would be self-help, or small community programs that are, for example, in gyms or community venues. Generally, the input and the use of personnel is quite heavy.
Okay. Thank you so much for providing us further detail for that question. We do have another question here, and that is, how does the health at every 5 movement fit into this evidence and conclusion?
Sorry, I didn't catch that. Can you repeat the question?
Definitely. So how does the health at every 5 movement fit into this evidence and conclusion? I'm not sure.
Yeah. I have the greatest sympathy with the organization, and I think all we can do is say that people should be allowed to have the facts so they can make a choice about what they would like to do about their weight and whether they want to remain at their current weight, or because they see that there could be health benefits, decide for themselves if they want to try to lose weight. It's entirely up to them, but I think it's helpful that people are aware of the facts, but they should not feel pressurized in any way to do these things. We know that weight loss doesn't work unless the people want to actually lose weight themselves, and often the health benefits are the furthest thing from people's mind in terms of what motivates them to undertake weight loss.
Thank you so much for answering that question. We have another one here about if it's possible for you to speak a little bit on some of the implications of grade, so really low versus high grade evidence and the implications of those.
Yes, we did undertake grade for all our main outcomes, and the high quality evidence related to mortality and cardiovascular events. Cardiovascular mortality we graded at moderate quality, and cancer mortality and events were very low quality. Grade uses 5 different measures in the circumstances we have here to assess the level of evidence. And those measures are risk of bias, inconsistency, indirectness, imprecision, and publication bias. And really, for many of these things, particularly for the cancer data, they fall down. But for mortality, we reckoned that the data was high quality. We had done everything we possibly could to reduce bias. The confidence intervals were narrow. The results were very consistent in all the different populations and seemed relevant to a wide range of settings. So that was our interpretation. And we did ask somebody not involved to the study to also do grading for us for our outcomes, and came up with the same ratings for the outcomes.
Excellent. Thank you so much. So another question that's come in is, how does this review compare to other similar research in the area? I know earlier in the presentation you mentioned the Krajewski review, but is there any additional add-ons or anything you'd like to speak to in that regard?
As far as we are aware, there are no other systematic reviews which have looked at randomized trial evidence and these outcomes. I mean, there are systematic reviews that have looked at randomized trials of weight management and, for example, diabetes prevention, but not for cardiovascular mortality, cancer mortality, and cancer and cardiovascular events or all-cause mortality. And it is particularly difficult to do these reviews because these days the weight loss data is so enormous, and because the kind of outcomes we're talking about are not necessarily in the abstracts, you won't pick up these trials through database searching. If you decided to do a systematic review, you would not pick up these trials. It's only because we have our register of trials that we started way back in 2002, and that includes trials back to 1966, that we have used for other evidence syntheses for technology assessments, that we have the full text of all these trial reports and can go back and look for them. So it's very hard for other people to actually undertake these kind of reviews. So we haven't come across any others at all, but we do plan to update this.
Excellent. Thank you so much. And thank you, everyone, for providing such great questions for us during this question and answer period. So right now what we're going to do is we're going to move on to the next polling questions, but please feel free. Oh, I just did see that one other question popped up, so I'm going to ask it before we move on to the polling questions. This question is, would it be possible to do a similar systematic review, but using DALY or QALY as outcomes rather than mortality or incident events?
Yes, in fact, that's a very good idea. There has been a little work done in weight management, reviewing the evidence for QALYs or disability-adjusted life years. It's rather disappointing because there are very, very few trials that have presented these data. So it would be a good thing to do in the future. And I think generally there has gradually been an improvement in collecting data from weight loss studies that will help to allow this to happen in the future, because increasingly health economists are interested in looking at these outcomes. But as far as I'm aware at the moment, it probably wouldn't be particularly revealing in terms of the overall systematic review.
Thank you so much for answering that. And now what we're going to do is move on to another polling question that we have for everyone today. And this question is, the information presented today was helpful. Strongly agree, agree, neutral, disagree, or strongly disagree. So do you feel the information presented to you today was helpful to your area of work? And as I'm seeing the answers coming here, it's really nice to see that the majority of people strongly agree or agree that the information today was helpful. So that is excellent to see. So moving on now, we're just going to discuss briefly at this point in the presentation a few options for ways that you can interact with health evidence moving forward. So these include visiting our website, registering to receive our monthly tailored registry updates, and or the monthly newsletter to stay up to date on new research and upcoming events. Tell your colleagues about healthevidence.org. Follow us on Twitter using the @healthevidence handle. Encourage your organization to use health evidence to search for review-level evidence to inform programming, planning, and policy decisions, and or contacting us to suggest future topics for webinars or provide feedback on the series. So next what we have is our last polling question of the day. And with the items that I just mentioned in mind, we would like to get your thoughts on what your next steps are after learning about this review-level research on weight loss interventions. So is it accessing the full-text systematic review, accessing the quality assessment for the review on healthevidence.org, considering using the evidence, or telling a colleague about the evidence? And as the answers come in, it's great to see that people are really interested in accessing the systematic review as well as the quality assessment. There's also lots of people that are considering using the evidence and telling a colleague about the evidence as well. So multiple of these options apply, and it's great to see that people will be engaging in several of them. So that's excellent to see. So to bring us to the end of the question period and the end of our time, I would like to give a big thank you to our presenters as well as to our audience today for posting questions and making this a really engaging and stimulating session. Our final reminder is that a copy of the recording and the PowerPoint presentation will be posted online in the next week or so. So I'd like to say thank you all, and thank you, Alison and Sam. And I'd like to throw it to you, Alison and Sam, to see if you have any final words for us today.
Thank you. Thank you very much.
Yeah, I don't think we have.
We've enjoyed presenting our results.
Thank you. Thanks, everyone.
Excellent. Thank you again very much, Alison and Sam, and thank you again to everyone for joining us today. And we hope that you all have a great day.
Okay, thank you.
Thank you.
Thanks. Bye.
Bye.